Welcome. Thank you for joining us for today's program entitled Vaccine Equity, a Global Perspective on COVID-19 Vaccine Distribution. We're honored to be joined by Safura Abdool Karim for today's important discussion. My name is Chad Hoseth. I'm the Assistant Vice Provost for International Affairs in the Office of International Programs at Colorado State University. We're thrilled that our international programs team is able to continue providing virtual programs such as today's event designed to inform and inspire. Be on the lookout for future events, including our 2022 International Symposium, which will be taking place next February. A few housekeeping notes before I introduce today's speaker. First, our featured speaker will share some prepared remarks, and then after those remarks, we'll reserve ample time at the end of towards the end of today's event for a series of questions and answers and discussion. So if you would like to have your question included in our discussion, please enter that in the Q&A box at the bottom of the screen. Enter that right now. We'll be looking at questions and we'll be sharing as many of those questions with Safura as we can during today's program. Additionally, closed captioning is available for today's event. Feel free to enable that feature at the bottom of the screen. And as you can see, today's event is also being recorded and available to rewatch at your leisure into the future. Finally, I do want to offer a special word of thanks to Shauna DeLuca with the International Programs team, who always makes these great events happen. Join me in thanking Shauna for pulling today's event together. And now, our featured speaker. Safura Abdool Karim is a public health lawyer working at the intersection of disease prevention and law. She's a member of the African CDC's African Vaccine Delivery Alliance, has degrees in global health law and currently pursuing a PhD on constitutional rights in non-communicable diseases with a special interest and expertise on issues of vaccine equity, legal issues related to the COVID-19 response, and also using the law to improve health outcomes more broadly. So with that, I'll turn the floor over to you, Safura. Thank you again so much for joining us and sharing your insight with Colorado State University today.
Good morning, and thank you so much for having me. I'm just going to share my screen, and so I can begin my presentation with some slides. Really, I wanted to take this opportunity to share what I believe is my unique perspective with those of you at Colorado State University, and that is the perspective of somebody who lives in Africa and who is experiencing this pandemic and vaccine access as an African, which may be something that not a lot of you come across in your daily lives. It may not be on your news channels and news TVs, but it is an incredibly important issue. And I'm really so grateful to have the opportunity to share this experience with you and to talk to you about what I believe to be one of the biggest challenges facing us today. So just a brief overview of what I'm going to cover in the next sort of 25 to 30 minutes. And then, of course, I welcome any and all questions that you have. I'd like to begin by talking about where we are in global COVID-19 vaccination. So not where is the US or where is Africa, but where as a globe do we currently stand? I'd then like to talk a little bit about why where we are right now is a problem, not just for people like me who live in Africa, but for those of you in Colorado and in the rest of the US. I'd then like to touch on how we got to this point and what we can do to change the state of play. And then briefly just talk about what we can learn from this for future pandemics and what types of measures we can put in place for the long-term sustainable access to biomedical interventions like vaccines. So where are we? This is, I think, an oft-used map from a group called Our World in Data, which is tracking vaccination rates across the globe. And basically in this map, the dark green symbolizes high rates of vaccination and the light green symbolizes low rates of vaccination. What you can immediately notice is that there are some parts of the map that are deep dark green. So that's places like the US, Canada, and wealthier parts of Europe. And what you will notice is that the continent of Africa is awfully pale. We crossed the threshold of having over 50% of the world's population vaccinated. According to Our World in Data, 52% of the world's population is vaccinated. But of that, only 4.6% of people in low and middle income countries are vaccinated. So that just puts into perspective how deeply unequal COVID-19 vaccine access has been. And we have termed this vaccine inequity vaccine apartheid, because what we see is that COVID-19 vaccine access is being determined by where somebody lives, what country they're from, and their geographical location. If you look at this graph, which is taken from the New York Times COVID-19 vaccine tracker, what you see is that huge proportions of the US population, of Latin America, of Europe, and even of the Asia Pacific are reaching a majority of their population being vaccinated, whereas Africa at the bottom has less than 10% of its population vaccinated. But this vaccine apartheid is actually not just about geography. It's actually more about income. And that's illustrated in this graph over here, which shows you by income where vaccination levels are. And what we notice is that the low and lower middle income countries are well below 60% of their populations vaccinated. And in the high income groups, you can see these countries are clustered at between 60 and 80% of their populations being vaccinated. To put it a little bit differently, the US itself, just one country, has administered over 440 million COVID-19 vaccines from various manufacturers, including Pfizer, Moderna, and Johnson & Johnson. And this is as of the 14th of November. In the same period, the entire continent of Africa has administered less than half of that. We've administered just over 177 million vaccine doses in the entire continent. And what's worse is that that's not going to change anytime soon. If you look at this graph, this map rather, shows you when we can expect to see a majority of a population vaccinated. And while South Africa, which is where I'm from, is a light blue country set to be achieving majority of its population vaccinated by the middle of next year, most of Africa and substantial portions of Asia are looking to be vaccinating up until 2023 to achieve a majority of their population vaccinated. So this is a serious issue. There's no doubting that there is deep inequity in the way that COVID-19 vaccines have been rolled out. And what we're seeing is that we thought that, oh, it may just be a case of the rollout in low and middle income countries is delayed. And once the wealthier countries have vaccinated their populations, they'll begin to give us doses. But we're actually finding that that's not the case. There was a brilliant quote from Nick Dearden, which said, "The rich world stance is not simply me first, but me first, second, third, and fourth." Now, the reason that that graph, the map I showed you with the different colors, is showing doses being needed up until 2023 is because many wealthy countries have begun introducing things like third booster shots of Pfizer. They've been throwing away expired doses and been purchasing even more doses to meet that need for the third booster. So what we're basically looking at is that for the next year and a half, most of the low and middle income countries that have received barely any vaccines will continue to have that state of play. So you may be thinking to yourself, sitting in Colorado, why is this a problem for me? And I loved this picture from a rally that was hosted in New York City, where basically they said that there is a need for vaccines to be made equitably available to all countries across the world because people are dying. So at one level, there's undoubtedly a moral imperative to address this vaccine inequity. Fatima Hassan and others have written to the British Medical Journal calling this vaccine inequity a crime against humanity. There are protests happening all over the world. Advocacy groups are calling for a people's vaccine, they're calling for patent protections to be weakened, etc. So there's a growing consensus that this is just not a morally sustainable position. But beyond that, there's actually a health imperative to also ensure equitable access to COVID-19 vaccines. And that really stems from the fact that the virus itself doesn't really respect borders. And for example, the Free the Vaccine movement said, in order to end the pandemic anywhere, we must end the pandemic everywhere. And that is the truth. Until we have a majority of the world's population vaccinated against COVID-19, we're going to continue to be experiencing this pandemic. We're going to continue to see variants of concern arising, and the threat is not going to go away. Beyond this, there's also an economic benefit to ensuring equitable vaccine access. The International Chamber of Commerce commissioned a study that said that if vaccines were not made accessible to the rest of the world, the global economy could lose up to $9.2 trillion. And that's not just the low and middle income countries that are going to lose that money. That loss is going to be felt by everybody in the entire world, because the continuing pandemic is going to impact trade, it's going to impact business, it's going to impact travel. And so there are a lot of reasons why the situation of vaccine inequity is a problem. So hopefully I've illustrated that the current situation is not tenable. I'd like to now touch on how we got to this space. How did we end up in this terrible situation of such massive disparity in COVID-19 vaccine access? So we all know that the COVID-19 vaccine development was a scientific success story. It took less than a year from the virus being discovered and being sequenced in January of 2020 to the first effective vaccine being results being announced in November of last year. And there are so many different types of COVID-19 vaccines available now. There's the Pfizer vaccine and Moderna, but there's also others like Sinovac and Sputnik, which were developed in China and Russia. But when we begin to look at where the vaccine was developed, we begin to see that of the vaccines that are currently in use, almost all of them were developed in high-income countries, with the exception of those that were developed in China. And the same picture is painted when you look at vaccines that are currently in phase 4 and phase 3 trials. So immediately we can see that there's a concentration of where these vaccines are being developed and consequently where they're being manufactured. We also found that there was something concentrated about the way these vaccines were funded. The COVID-19 vaccines were not funded the way that traditional biomedical innovations are funded. Usually, a pharmaceutical company creates a biomedical intervention, they take on the risk of doing years and years of research and development, and then take on the financial burden of putting that intervention through trials. In this instance, the single biggest investor in COVID-19 vaccines was actually you who are in the audience. The US taxpayer was the biggest contributor to global development of COVID-19 vaccines. To put it into different perspective, this is how much money was given by, so the turquoise bar on the top is how much money was given from the public sector, and the red is how much came from the private sector. And what you can see is that really across different countries, the development of these vaccines was funded by taxpayer money, by public money. And so in many ways, it is rather strange to see something that was paid for with taxpayer money be considered a commodity for profit rather than a public good. But as much as this funding was given and led to the successful development of these vaccines, the funding also came with a pretty significant string attached. And that was something that has actually defined vaccine access up until now. And it's something called an advanced market commitment. In exchange for funding the development of these vaccines, countries that funded the development required that the company agree to give them preferential, if not exclusive, access to the vaccines. And what you can see here in this graph from Nature is how many doses per person each country subscribed to. So for example, the United States pre-ordered enough doses for each member of its population to receive 2 doses and created a preferential arrangement for a further 4 doses per person. Canada is probably the most extreme example out of any country, and I'm sure many of you have heard the oft-touted phrase that they subscribed to 9 doses per person. And in contrast, China and COVAX were left with less than 1 dose per the population they were supposed to be serving. So what we see here very clearly is that the wealthy countries that invested in COVID-19 vaccine development did so at the price of having preferential and exclusive access, to the exclusion of low and middle income countries. Now, at a global level, this map shows the vaccine contracts that were entered into up until March this year. It's extremely difficult to get a clear picture of how many doses different countries have committed to with which manufacturers, because of course, all of these things are shrouded in so much secrecy. But with a pinch of salt, this gives us a similarly clear picture. And this map really echoes many of the maps I've showed you, where the wealthier countries on the map are subscribed to many, many doses, and the poorer countries on the map have next to nothing. So this was really how the vaccine inequity was operationalized. It was done through contracts, and it was done through advanced market commitments. Now, people did see this coming to some extent. And so COVAX was created. It's a jointly led effort between the World Health Organization, Gavi, the Vaccine Alliance, and CEPI. And really it had 3 pillars. The idea was that it would subscribe and get advanced market commitments for 9 different COVID-19 vaccines. Now, this brings up a question that many of you may have, which is, why couldn't the low and middle income countries just fund development of COVID-19 vaccines? Why didn't they enter into advanced market commitments? And that is sort of found in the answer to this pillar of COVAX, which is that when the US and Canada and many other countries invested billions into the development of these vaccines, they did so without knowing whether or not the vaccines would work. The amount of money that South Africa, which is a fairly wealthy low and middle income country, invested in COVAX is more than our entire vaccination budget for a year. It's more than double, in fact. So many countries were not in a position to gamble that kind of money on vaccines that may not work. In the rest of Africa, many countries are actually reliant on Gavi as it currently stands to roll out their routine immunizations. They don't have enough money to buy routine immunizations, let alone pay the high cost of a COVID-19 vaccine. So we in the low and middle income sector were not in a position to be gambling money away or to be outbidding countries like the US when it came to advanced market commitments. So Gavi attempted to ameliorate some of this risk by attempting to create a portfolio of 9 COVID-19 vaccines so that the risk would be spread across those 9 different candidates and hopefully one of them would work. They also sought to set up mechanisms to scale up manufacturing and the rollout of a COVID-19 vaccine through system strengthening and healthcare infrastructure strengthening. And most importantly, they were attempting to ensure that anybody who wanted to participate in COVAX could get enough doses to cover at least 20% of their population. And the way it was supposed to work is that the vaccine doses that became available were supposed to be allocated proportionally based on the size of a population, which would mean that no country would get more than its neighbors. Everybody would get the same amount. Now, initially, when COVAX was introduced, a lot of wealthy countries pledged to participate in and support COVAX. But when the Pfizer results were announced and shortly thereafter the AstraZeneca results were announced, countries quickly descended into relying on bilateral agreements to expedite their COVID-19 vaccine access. And this actually completely undermined COVAX efforts. COVAX was unable to purchase doses of vaccines because they had all been monopolized by wealthier countries. And this leads to something that has been termed the many flavors of vaccine nationalism. There are a lot of different factors that have resulted in the inequity that we've seen. Part of it is the advanced market commitments and bilateral agreements that I've spoken about. But we've also seen that there have been initiatives like the Operation Warp Speed and other efforts from countries like the United Arab Emirates and Brazil to expedite rolling out of COVID-19 vaccines. In some instances, even agreeing to roll out vaccines that have not been proven as effective so that they can be the first ones to get a dose. And as I also mentioned with COVAX, there's been non-participation in solidarity efforts. So things like CTAP and COVAX, which were created by the WHO specifically to ensure that the COVID-19 vaccine could be distributed equitably, have been deeply undermined, and most wealthy countries have opted not to participate in them. We've also seen that countries that have supported the trials of these vaccines haven't been given any kind of post-trial access. And South Africa is a really good example of that. Trials for Moderna, AstraZeneca, and many other vaccines happened in South Africa on South African citizens, and those citizens were not given any kind of access to the vaccines after the trial was over, including those who had the placebo. We've also heard recent stories about vaccines that are actually manufactured in Africa being exported to the European Union. We've heard about wealthy countries having excess doses that are expiring, and so they've been destroyed rather than being donated or given to poorer countries. And we've also seen many countries pledge millions and millions of doses and not actually deliver on those commitments. And the last thing we've seen more recently, which is incredibly worrying, is a movement from big pharmaceutical companies to scapegoat low and middle income countries and say that the reasons for low vaccine uptake are not to do with availability of doses, but to do with things like vaccine hesitancy or weak healthcare systems. Despite most big pharmaceutical companies initially committing to ensuring that there's equitable vaccine access, what we actually found at the end of the day is that only one company actually made any kind of meaningful commitment to providing equitable COVID-19 vaccine access. And that was AstraZeneca, who very early on entered into an arrangement with the Serum Institute of India through an exclusive voluntary license. And under the terms of that license, the Serum Institute of India would be given exclusive rights to sell vaccines to low and middle income countries on condition that the prices of those doses were made affordable. Of course, this caused immense problems when India experienced the Delta variant and the production of vaccines was severely disrupted because there was only one place that was servicing and providing doses to low and middle income countries and to COVAX. We've also seen that the type of vaccines that are available is heavily dependent on where you live. And this kind of flows from my point about the Serum Institute being the only place that is servicing low and middle income countries. These are maps of where different types of vaccines are currently available and being rolled out. And what you can see is vaccines like Moderna, Johnson & Johnson, and Pfizer are overwhelmingly being rolled out in high-income countries, with a handful being rolled out in places like South Africa and Brazil. Whereas most of the low and middle income countries that are receiving doses from AstraZeneca, Sinopharm, or Sputnik. And this has a bearing on something I'll touch on a little bit later, which is to do with the kind of vaccine nationalism that's at work when certain types of vaccines are not recognized as valid in other countries. The final thing I'd like to touch on before moving to hopefully a more positive side of solutions-oriented thinking is around the abuses that have arisen from big pharmaceutical companies. What we've seen when it comes to the COVID-19 vaccine and its access is a handful of companies exercising immense power and truly dictating the health of billions of people across the globe. Big pharmaceutical companies have opted to prioritize access for high-income countries. They've also opted to profit over the vaccines. And in many instances, leaked documents have demonstrated that these pharmaceutical companies are actually charging low and middle income countries higher prices than high-income countries, even though the low and middle income countries are less able to afford the vaccines. In certain instances, we've even heard of countries being required to put up sovereign assets as security for the doses they want to receive. And all of this is shrouded in so much secrecy because governments of these countries have been made to sign non-disclosure agreements. There's a complete lack of transparency around the terms of these agreements, where the negotiations are, and how many doses have actually been committed. And finally, and most troublingly, there's been a concerted effort to block the application for a TRIPS waiver. And again, when you see this map, it looks so similar to the other maps I showed you before. This is a map of who is opposing and supporting the TRIPS waiver. Now, the TRIPS waiver is an application that is led by India and South Africa to argue that COVID-19 vaccines are a public good and so should not be subject to IP protections. In other words, IP protections should be weakened. Now, President Joe Biden a couple of months ago announced that the US would support the waiver, so this map is a little bit outdated, but overwhelmingly high-income countries are not supporting the waiver and in many instances are actively blocking it, preventing low and middle income countries from developing their own vaccines. So I also touched briefly on the scapegoating, and these are just some quotes from different pharmaceutical company CEOs. For example, the CEO of Pfizer said that the reason that there is a slow vaccination rate in Africa is not because there's a lack of doses being available and Pfizer has refused to sell African countries doses, but actually because we're just far more vaccine hesitant than other countries in the world, which is actually incorrect. Africa has one of the highest rates of vaccine acceptance in the world. We've also heard about the CEO of AstraZeneca announcing that COVID-19 is now endemic, and therefore AstraZeneca will begin to profit from the COVID-19 vaccine. And finally, we heard just a couple days ago that the US government has decided to purchase 200 million doses of Pfizer, doses that could be going to low and middle income countries. And these doses are for third booster doses, something that has not even been approved by the FDA. So what we're seeing is that vaccine nationalism and vaccine apartheid is not going away. It's actually getting worse. So how do we change this? Many people have suggested that the solution to this is in the form of high-income countries donating doses, excess doses to low and middle income countries and to COVAX. But what we see is actually that very few countries are willing to follow this donation model, but also that very little of these doses have actually been donated and have actually been delivered to low and middle income countries. This is another graph that was made by, it was published on Think Global Health. And what we can see is that firstly, most of the countries haven't pledged all that much, but even those who haven't actually delivered even half of what they committed to delivering. And if we look again at that infographic I shared earlier, what one can see is that although we have 177 million vaccines being given in Africa, most of those are actually have been acquired through bilateral arrangements. So in other words, between a government entering into an agreement directly with a pharmaceutical company, the way that many high-income countries have done. And that means that the most vulnerable and poorest countries in Africa are actually not getting as many doses. I also just wanted to point out that a high number of the doses that have actually been received have actually been administered. 3/4 of them have been administered according to this, which is dated 22 September. So a lot of the statements coming from the CEOs justifying the sort of vaccine apartheid and low vaccine rates in Africa are actually erroneous as well. So if the donation model doesn't work, what are the solutions? Well, in the short term, there are 5. The first is high-income countries should stop hoarding vaccines. And then they should declare COVID-19 vaccines a public good. And that includes things like supporting the TRIPS waiver and treating vaccines not as a donation, but as a matter of equity. And by moving away from that donation mindset and model, we can begin to actually turn it into something that is sustainable. For example, there was an article that was written a couple of weeks ago where the head of ABDA was speaking to the New York Times, and she spoke about the incredible logistical struggles that come with the donation model, because you don't know when they're coming and how many are coming and what type of vaccines are coming. It's impossible to prepare. It's impossible to make the arrangements that are needed. You don't know if you're getting a Pfizer vaccine that requires extreme cold storage, or if you're receiving a Johnson & Johnson vaccine that can be kept in a normal fridge. You have no idea how many healthcare workers you need to mobilize to administer those doses in time. And you don't know when those doses are expiring, because many of the donations are for expiring doses. So there's a complete lack of coordination and an inability to prepare that's further hindering the rollout of what limited vaccine doses are arriving. It is also really important that high-income countries begin to support solidarity efforts. The same solidarity efforts that they've previously opted not to participate in are really, really important to ensure that equitable vaccine access is realized. And then finally, we need meaningful transparency when it comes to bilateral arrangements. We need to have a clear picture of which countries have oversubscribed doses, how many doses are becoming available, and what the terms upon which those doses were sold were, so that we can ensure competitive pricing, fair pricing, and also ensure that the terms of the agreements are not unduly onerous. I'll end by just drawing out what we should bear in mind for future pandemics. In the long term, we need to seriously address issues of vaccine inequity. And we do this in 5 ways. The first is we need to create strong solidarity systems. Part of the reason why COVAX and CTAP haven't been successful is because they're voluntary, and countries have a choice whether or not to opt in and opt out. And so those with disproportionate power are having the ability to opt out. We also need to increase vaccine manufacturing capacity in Africa and in the rest of the low and middle income countries. And that, I'm very happy to report, is happening in strides at the moment. But many of the newly formed vaccine manufacturing capacity, or the arrangements that are being put in place, are actually for subsidiaries of these big pharmaceutical companies that have been abusing the pandemic and abusing their power within the pandemic. And so it is important, when we think about increasing vaccine manufacturing, to make sure that that increased vaccine manufacturing is not going to result in a repeat of what we saw, where vaccines are manufactured in Africa but exported elsewhere. We also need to really enforce the Doha Declaration. The Doha Declaration is an instrument that allows for IP protections to be weakened when there is a public health emergency. It is stunning to me still that it is being debated whether or not the Doha Declaration is applicable in the context of a COVID-19 pandemic, particularly given how unprecedented a public health emergency it actually is. In addition, we need stronger regulation of pharmaceutical companies. And this is perhaps the most tricky because many of these companies have strong vested interests, and there are a lot of politicians who are engaged with them in various different ways, which makes regulating them very difficult. But the reality is that a handful of companies shouldn't be wielding so much power over the health of an entire globe. And then finally, we need equitable benefit sharing arrangements so that when a country participates in a trial and when citizens of a particular country are given a placebo or given access to a vaccine through that trial, we can ensure that that contribution to the development of that vaccine is appropriately recognized. So those are just some thoughts about the state of global vaccine access across the globe. Thank you very much for your attention and the opportunity to present to you on this important topic, and I welcome any questions you have.
Thank you so much, Safura. If we were in person, you'd be hearing a whole lot of applause right now. So thank you very much for sharing your presentation and insights with us. We have some questions coming in already, but I'll remind everyone, if you'd like to have your question added to the conversation, please add it in the Q&A box at the bottom of your screen right now. Let me first start kind of as a jumping off point where you just ended. And a little bit of that is the where do we go from here? And I'll draw from one of your last slides where I think it was the second box you noted, one of the things we should do is declare COVID as a public good, right? This is a matter of equity, not just a matter of donation. And one of our questions is around communication that might touch on this issue. So what are your thoughts on the failure of public health communication surrounding COVID-19? Obviously, there are a lot of messaging that we've had, certainly in the United States, around personal responsibility, but we have not seen as much messaging around the importance of vaccinating the world in our some of our engagements here in the United States. What do you see globally, and to what extent do you think we should be thinking about public health communications moving forward?
It's a very tricky issue because I think the media landscape and the messaging that you receive is so radically different to countries like South Africa and countries who are in low and middle income settings. There are so many advocacy efforts. It feels like you can't go a week without hearing some story about vaccine equity, in South Africa at least. We've had the people's COVID-19 vaccine movement, which has been seeking to argue for COVID-19 vaccines to be made freely available to everybody on the planet. And they've been messaging and advocating around this issue since March last year. In fact, even my own advocacy efforts began in March last year. But what's so terrible about it is despite the amount of advocacy and despite the amount of effort that there's been to try and put this onto the global agenda, it's all just fallen on deaf ears. It hasn't received the type of attention that it should. And I'll also just say, the other person who's been incredibly vocal about this is the director of the WHO, who's constantly called for equitable vaccine access, also dating back to February last year. And so it's terrible to know that we knew this would be a problem. We had the tools at our disposal to address this, and yet nothing was done up until now.
What you just said, something I'd like to follow up on, that the communications sort of from a public health standpoint in the United States appear different than what you're experiencing in South Africa. Can you paint a picture for us? What does communications look like to the population in South Africa regarding vaccine access and kind of touching on the vaccine hesitancy question as well too?
So I think South Africa is in a very complicated position, like many countries like Brazil. Those countries that fall into that band of being an upper middle income country are constantly having to balance a tension between public demand for a vaccine now and needing to show solidarity. And so even within South Africa, the truth is we have over a third of our adult population has been vaccinated. We've been able to secure ample doses, but that has been through bilateral arrangements. And so we've got groups of people who are advocating for the government to take steps like enter into bilateral arrangements and things like that. But then we've also got this element of regional solidarity, where, for example, our president donated I can't remember actually how many it was. It's not a million, it's way more than that. But millions of doses of AstraZeneca to the African Union. And while that was regionally lauded as a brilliant decision, in South Africa, that decision was heavily criticized. Why are you giving away our doses to other people when we need them? But at that time, of course, the variant that we had prevalent in South Africa meant that those vaccines were not as effective. So there's an extreme tension in countries that are in South Africa's position, because we have people who are advocating on behalf of the entire continent for people to get access to these vaccines, but at the same time, we're having to leverage on our own existing economic power to secure vaccine access. So we're definitely not the poster child for vaccine equity, but at the same time, South Africa's been spearheading many of the wonderful initiatives you heard about. I mentioned briefly the World Trade Organization's TRIPS Waiver. That was South Africa co-sponsoring it with India to fight for vaccine equity. So it's been quite mixed, I will admit that.
Yeah. Another factor that kind of, I think, enters this conversation sometimes is vaccine diplomacy, geopolitical sort of tension, and in some cases opportunism as a result of vaccine distribution. We had a session earlier this year talking about China, and the notion of vaccine diplomacy came up a lot. Your chart suggests that maybe the amount of donation is not necessarily as high as I might have anticipated. I'll say that personally, and yet the commitment seemed to be honored at a far greater rate than several other countries. Can you speak a little bit to this notion of vaccine diplomacy? And do you think that's, I don't want to say good or bad, but offer reflections on the positive potential, but also the negative outcomes that may emerge?
So I think that, again, this was a double-edged sword, because in many instances, the only way that middle-income countries were able to access vaccines was through the types of vaccine diplomacy that Russia and China were engaging with. So if you look at countries like Brazil and Morocco and the United Arab Emirates, most of those countries were rolling out vaccines developed in Russia and China. The double-edged sword is that those countries were very cagey about sharing too much detail of the data surrounding the efficacy of those vaccines. And I sort of glossed over it slightly, but in some instances, countries were willing to roll out these vaccines without proof that they were effective before phase 3 trials had been completed, in order to get access to vaccines now. And this was particularly the case around late last year, so between September and kind of January, where countries were just trying to get any vaccines they could. And in fact, South Africa is one of the countries that hasn't approved the Sputnik vaccine for use in South Africa because of the lack of data available. So it has been immensely successful, not just in terms of vaccine diplomacy, but in terms of giving people meaningful access to a vaccine. There are several countries in the world that wouldn't have such high rates of vaccination had those countries not chosen to prioritize access. But at the same time, we have these question marks about the kinds of vaccines that are being made available and their quality, actually, at the end of the day. Are they as safe? Are they as effective? Those are the questions that linger when it comes to these issues.
Let me combine two questions that have come through regarding global systems. That's all right. Is there a better entity or system outside of COVAX to distribute vaccines? And how is WHO working to address vaccine hesitancy in more equitable distribution? Curious if you can offer reflections on the future of these kind of transnational systems.
Sure. So I'm very proud to be part of the Africa CDC's African Vaccine Delivery Alliance. as well as their partnerships for African vaccine manufacturing. And I believe this is the key to sustainable systems that will make vaccines and other biomedical interventions accessible in a sustainable fashion. Both of these mechanisms have created systems that can be used to pool the collective bargaining power of Africa, to purchase vaccines, to invest in vaccine manufacturing infrastructure, and to ensure in the future that this doesn't happen again. But the problem is all of these things take time. So I can't think of a place that knows its own context better than the countries that are experiencing this. So it's incredibly important that these initiatives be led by the countries that are responsible, that they're context specific and responsive to the needs of those particular countries. But at the same time, we need support from other countries. We're not a wealthy continent. We don't have the kinds of money and infrastructure to invest in these. And so we do need other people to come to the table and not see investment in these types of endeavors as an act of charity, but actually as an act of contributing to public good and public health at a global level. Now, I saw in the chat that there was a question about vaccine hesitancy and what is the reality of vaccine hesitancy in Africa. And I'd love to just address that because I'm sure it is a big question for people. There have been several studies, and I will say this, which is sometimes it's difficult to get a precise handle on what vaccine hesitancy looks like in a context like ours. But what I can tell you is that most studies have shown that less than 20% of Africans are vaccine hesitant. In fact, in many countries, vaccine acceptance is over 90% in African countries, which is significantly higher than most high-income countries. So if I can put it another way, most people in Africa want a vaccine, they just can't get one.
Mm-hmm. Wow. Thanks for sharing that. Here, I'll combine another couple of questions that have come in. One is, do you think that drug companies who have developed the most effective vaccines are doing enough to share their technology so other manufacturers can prepare effective vaccines? You touched on that a little bit in your presentation, but perhaps you could expand on it. And then also, well, maybe I'll leave it at that. I'll ask the next question next. Leave it at that.
So within the partnership, what we found is that companies have been incredibly proprietary and close-chest about their know-how and their tech transfer. And I sort of mentioned this issue of, instead of investing in vaccine manufacturing capacity, they're opening subsidiaries, which is really exacerbating the problem. It's addressing one small component in that, yes, we need more capacity, we need more supply of vaccines, but it doesn't address the underlying issues of inequity. It doesn't capacitate different low and middle income countries to produce these types of vaccines, because everything is contained within one private entity. The reality is these technologies should be a matter of public good. They shouldn't be subjected to patent protections. I mean, imagine a polio vaccine being considered proprietary, or a smallpox vaccine. It's been so rare up until the last 2 decades for vaccines to be under patent protection. So this is something that we're really having to struggle with as each of these new pandemics arise. And COVID is just one prism, or one crucible in which all of this is happening. But the reality is these issues have been in place since the Ebola outbreaks, swine flu, the original SARS that some people may remember. There were vaccines that were being developed all throughout these outbreaks, and there are very likely to be many more outbreaks. And in order to be prepared for those, we need to ensure that we don't just open factories that can produce vaccines, but that we capacitate those countries to be able to develop and manufacture their own vaccines and ensure that their own populations can be protected as well.
Right. Building on some of those comments, and again from the presentation, can you comment or offer additional insight on laws and actions regarding vaccines that support or inhibit distribution? Anything, I know public policy and some of the legal work is an area of particular interest for you. Can you comment a little more on what you hope might happen moving forward in that area?
So really, I think there are three components where laws currently act to hinder, but could actually be real facilitators of vaccine access. The first is around benefit sharing, which I touched on very briefly. It's this idea that if you contribute to the development of a biomedical intervention in some way, and it doesn't mean that you actually developed it. It could be that your country or your country's citizens contributed to the trial that showed that that product was effective. It could be that you provided the samples of the virus that was used to manufacture the vaccine, etc., that you should participate in the benefits from that contribution. You should have access to that biomedical intervention at an affordable price. And something like that was created by the WHO in the form of what we call the PIP framework, which is the Pandemic Influenza Preparedness Framework, where if countries were providing samples of an influenza virus, they would in exchange be allowed to purchase the vaccine that was developed at a lower price. We haven't seen that type of infrastructure be put in place for public health emergencies, but it is incredibly important because it facilitates quick and easy and equitable sharing of information across different countries, and then correspondingly ensures that there's equitable access to the benefits. So that's the first component. That would really be great if we could expand that. The second component is around intellectual property protections, which I think we've touched on quite expansively, but basically these things are a matter of public good. They shouldn't be in the hands of a handful of people. And I think that's the basic point. We should be allowing countries to manufacture them. We should be equipping people. Anybody who has the capacity to manufacture a vaccine should be able to do so. They shouldn't be barred from doing so because of IP protections or proprietary tech. And then the last component, which I really touched on very briefly, is the idea of vaccine regulation. And how it is contributing to vaccine apartheid. Some countries approved vaccines without having evidence of the efficacy, and they did that so they could get access to vaccines very quickly. We're now seeing something similar where countries are not recognizing Sputnik or Sinopharm vaccines. And that causes its own problem because most of the countries accessing those vaccines are low and middle income countries. So if you're not recognizing it, you're actually discriminating against a whole group of people who couldn't get any other type of vaccine. So there's a lot of complexity around the issue of regulatory systems and vaccines. And that's, again, that's such a direct area where the law has such a significant role to play that we really need to rethink a little bit.
All right. Earlier in your presentation, you had a picture of the world and talked about when we think vaccine distribution will kind of show up in meaningful numbers globally. And I think the African continent was end of 2023, right, and beyond. I think that was someone else's data though. So I'm curious, are you an optimist and think and are hopeful that that chart is inaccurate and that we as a global society will make greater progress over the next few months, or do you think that's right, or even maybe a bit too optimistic?
So that chart was actually based on a revision that COVAX had to make to its schedule. COVAX had to push its distribution schedule back significantly, partly due to the disruptions of the Serum Institute, but also due to this issue around vaccine supplies being purchased for third dose boosters. And that is really important to understand, is that wasn't originally, even with all the inequity that I described, that timeline was not the original timeline. The original timeline was that most countries would have a majority of their population vaccinated by the end of next year. So that issue and that sort of pushing back of the timeline is really down to this evolving nature of vaccine nationalism. I like to say vaccine nationalism hasn't ended, it's evolved. It's becoming more insidious, it's becoming less obvious, where we're seeing lots of countries saying, oh, we're gonna give you our doses, we're pledging millions and millions of doses, and then they don't get delivered. We're seeing CEOs of different companies saying, oh, you know, we do want to sell to you. It's just that you're not using the doses we give you. So it's become less express and explicit that they're favoring high-income countries. Instead, it's become this sort of subtle messaging. But really, unless we start turning that around, unless we start holding companies and unfortunately high-income governments accountable, and making sure that they deliver on their commitments and that they do actually commit to equitable access, that timeline is going to continue to be pushed back further and further. It's not going to go, vaccine nationalism is not ending anytime soon. It's just getting worse and worse.
Well, let me finish with then one kind of invitation to both, realizing you're talking to a community of students, faculty, and staff on the other side of the world from you out here in Fort Collins, Colorado. What is the last thing or the most important thing you want us both to take away from our conversation here today? And perhaps most important, what is the one thing you would hope we would do kind of from our station here at Colorado State University moving forward?
So I think the one key takeaway, if you take away anything from this presentation, is that a lack of access to COVID-19 vaccines in Africa is a problem for you, not just for me. It's a problem for everyone, and it's for that variety of reasons I outlined. And in terms of things you can do, it is completely within your power to contribute to vaccine equity. You can put pressure on your representatives to stop engaging in the many flavors of vaccine nationalism. You can hold private big pharmaceutical companies accountable and call them out for their behavior. I described to you how there were millions and millions of doses of vaccines being manufactured in Africa and shipped to the EU. Those doses ended up being sent back and are now being distributed in Africa because of an expose that was written in the New York Times. There is immense power in advocacy. These companies change their behavior based on what their consumers and their customers think and say. So if you can, I encourage you in whatever way you want to, whether it's on Twitter, whether it's through staging a die-in like they did in New York City, whether it's in writing to your representative, I encourage all of you to take some small form of action to recognize that the current situation of vaccine inequity isn't tenable and it should be addressed by both pharmaceutical companies and governments in wealthy countries.
Great words to end on, and great kind of, again, action steps for all of us to take forward. Thank you again so much for spending this time with us. This has been a remarkable event, just a great event. Thanks to all of our audience participants for the great questions. And again, I wish you all a great day. And again, join me in saying thank you to our great speaker, Safura Abdool Karim. Thank you so much. Have a great day, everybody.
Bye, and thank you for having me.
Thank you.